Good morning, Vera, or Dr. Joffe, as your patients call you.
Morning, Dr. E.
I am so excited to be with you today. We definitely are going to have to work really hard to keep this at a decent time frame because the two of us can go on and on about SM and it could last 2 to 3 days.
Mhm. That's right. I'm very excited to be with you. Thank you for
Yes, so it's just wonderful. And so, the reason we're getting together today is to talk about SM and autism.
Mhm.
And it's a really important topic because there's a lot of misconception out there, misunderstanding out there. And hopefully, between the two of us, with your so many years of experience and my so many years of experience and interacting and working with families with SM and autism, the misdiagnosis on both ends, it's critical for our listeners because there's so many listeners out there that are questioning and they're not sure and they're being told different things by different clinicians or educators. And I'm hoping we can kind of get it straight and kind of discuss and open up dialogue for even future discussions on autism and SM. So I guess to me, like one of the first questions we had is why do we want to talk about this today? And I guess I just answered this.
Yes, you did. And I think that
Any thoughts?
you have experience with patients that came to you with a diagnosis of autism, then you found out they had only SM. Same with me, or they came for SM, we find out they have autism, and the SM is mild or it was misdiagnosed. And then there are children who have both. So that's something that we know that is possible. And in the past, the same as we couldn't diagnose autism with ADHD, and now we can. We also are doing in our field of SM, we are realizing, and we have realized for a while already, but I think it's been more accepted that they can coexist, but we have to differentiate to see if they're
Yes.
both together or each of them separately. So,
No, excellent, excellent points. And I want to say I always felt a bit of a trailblazer with this, and I'll tell you why. Because for so long, I was told the DSM, which is you can go into, we're going to go into that in a little bit, but I just want to intro with this is that SM and autism can't exist together. And that if you have autism, you can't have SM. And if you have SM, and so for so long, I felt like I was like kind of, head a little bit like kind of like looking around the corner going, wait, this is not true. And I am not going to be able to listen to what some of these people are telling me. They're telling me this because they don't understand what SM really is. They're seeing it as kids that speak and don't speak, and that's what they're focusing on. And a
I
lot of the DSM talks about that. But as you know, and you and I were very, very passionate about this from the very beginning, and we connected over the fact that the comorbidities or the whys are
Mhm.
what shape this social communication anxiety that you not speaking again. I say it in every single podcast is a symptom.
Yes.
You
Good.
can have SM and you can have autism.
Yes.
And right?
Yes, I totally 100% agree. We can't deny all the cases that come through our doors that we see that. You and I see a lot of kids with neurodevelopmental disorders, that's part of our practice. And that's why we've been seeing them for many, many years. I started collecting data in 2006 with Dr. Andy Zimmerman and more recently with Anita Ponjawi. And the way that the reason why I started collecting data is because I had this at my face and I was looking at the DSM and I couldn't really match what I was looking at. And
Exactly.
so that's why, we started getting some data and you have data, information, scientific data, and there have been some other pieces of research on this topic too, although there has been some resistance in acknowledging this. I just want to say that you said about the DSM, and I'm going to, mention the DSM-5R, which in the case of SM, it says that it can be attributed exclusively to ASD or to a speech and language disorder or something like that. So I would take this exclusively as the word to include, it's not due exclusively to ASD, but it can coexist. And in the SM, that's the SM. And in the ASD, we can go over that afterwards in terms of the diagnosis, because what would differentiate the two is really important for us to look at that, the DSM, but also levels of impairment in the repetitive behaviors and, the obsessive and compulsive tendencies for autism. So,
Yes, and I would say, just to kind of put in there before we kind of look at a little bit of research to give families some information, listeners,
yeah.
professionals listening to this, is that one of the biggest things I see, and again, I think I'll reiterate this as we move along in this podcast, is the social puzzle, the know-how, a really tremendous differentiation between having SM only. Well, I don't want to say SM only, because SM to me is a symptom. And
Right.
having the social communication anxiety without ASD, how about that? Is that most of those individuals understand the social puzzle. Their anxiety from other reasons impact them from having maybe a social connection, communication, interaction in settings that create anxiety for a variety of reasons. But those with autism, whether they have SM or they don't, it's the social puzzle. It's
Mhm.
the difficulty figuring out the social nuances. And I see this over and over, Vera, in my practice, where families come thinking for many, many years, this is SM. I would say on a weekly basis, I come in contact with a family of a teenager who has been diagnosed with SM. And as I'm working with them and assessing them, I'm like, whoa, yes, this child has SM symptoms, but guess what? They're on the spectrum. They have so many symptoms, and that social puzzle they cannot figure out that causes them avoidance, stress. And as a result, it frustrates parents because they just don't get why their child doesn't understand the social puzzle, or they don't even realize that. They just think it's not speaking. So they may work with somebody that's about speaking, trying to get them to speak, and the anxiety that goes up and the frustration that occurs along the parents' experience, the child's experience, avoidance, if they're aware of that, is just tremendous. And
Yes.
then having those difficult conversations with families when you see autism. Imagine this happened to me 2 weeks ago, a 19-year-old been funneled for years into SM only, social anxiety, classic autism, classic. How it was missed from treatment, I don't know. We ended up doing testing, and yes, this individual, 19 years, and to have that difficult conversation. So I just wanted to put that out there because I do believe we have listeners that are on the fence. Does my child have autism, SM only? Like, what's going on? So yes, there's a lot of misunderstanding.
Yeah,
So
I agree with you. I think that I too get cases that come with the diagnosis for a long time, and of course, the later, the more difficult it is for us to treat a teenager versus a child. I think that the key here is to do a very comprehensive assessment, as you said, and I think that when we have little kids, we can watch the child as the child relates to the parents at home. And also, I ask parents to bring me videos of when they were babies, to see the shared attention, to see the eye contact. This is for more severe cases of ASD, which we can see more clearly. The most difficult one is to differentiate or to diagnose the ASD level 1, the highest level of functioning of ASD, when we have SM, because the pure definition of selective mutism are children who do not speak in certain places, but they, with some people when required, as opposed to speaking regularly at home with their parents and with other people they feel comfortable. So I really like to include videos from home so that I can see the natural relationship and the natural social exchange, and taking turns, and theory of mind, like you said, the social cues in video. Because quite frequently we hear that no, they're fine at home, we speak fine at home, but they really are not. They have a one word sentence, or they don't have the eye contact, they don't have the empathy, which is really important for teenagers and young adults for us to ask, and older children school age. But I think that it's really important to do a good assessment. Developmental history is really important, and to
It
see the show the signs early on. But again, we are finding out more and more that the more autism is being diagnosed, not because there is an epidemic, but because there is a higher sensitivity for it and more information and knowledge about it. So it's the mild and the level 1 type of autism that is really what we're dealing with here, that is more difficult to differentiate from SM or to see if it's there co-occurring. And the best way to diagnose is to use scales, to use the scales that are really good with autism, like you use the others. And I use some questionnaires that actually do not help much in terms of differentiating, because a lot of the social avoidance, like you said, the social communication avoidance, you said, is inflated when we give an autism scale to a child with SM. But we really have tools that we can use, a multi method, and talking to a lot of people, observing at school, observing at home with a video or with Zoom, where you watch the family during a natural kind of interaction. And then you have the tools to differentiate the two. I have other items that I can mention afterwards to you. There's some of the things that we look at, but I really like the fact that you focus on the social cues, theory of mind, and shared attention and other areas that.
You brought up a couple really good points. One of the things that happens at the center is we'll get calls with, my child has SM, I just want to get treated. What do we do? And it's like, whoa, 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 stop, step back. So this is why for us, the selective mutism evaluation, which is an hour and a half evaluation, some pre-forms for families and schools to fill out. And then we meet with this family and this child, teen, or adult to be able to do a assessment to determine what are those whys, comorbidities, some of the other coexisting challenges, toileting, eating behaviors, sleeping issues, and et cetera, and their baseline stages of social communication, which we use the SCI, the Social Communication Anxiety Inventory. And what we do is we get a kind of a clinical picture of what that individual is and what we need to address in treatment. So to be able to walk into a therapist office and just start treating SM, quote unquote, I don't know how that can be successful with so many, because you're missing those comorbidities, those whys that have to be addressed. And also with autism, what is this child like at home? What are they like out and about? And that's a really important question that we need to figure that out. And through the questions asked, you learn with individuals with autism that their language impairment, some of their motor difficulties, some of the sensory processing that
Yes.
is more exaggerated, they're like the same in setting to setting. Their speech may be the same in setting to setting. So yes, they may be not verbal and they may not be expressive, initiative, and elaborative, but as you said, they're not doing that at home either.
Yes.
So you have to determine, is there a change in social situations to make that SM diagnosis? But to me, for any of our listeners that are going to clinicians for evaluations and treatment, I'm hoping that they're doing a comprehensive evaluation to be able to at least screen for these difficulties instead of jumping in and trying to give them brave points to talk if
Yeah.
they're not yet ready to do that. So to me, that's really, really important. And as you said, what we pick up in the selective mutism evaluation is, do we need to do additional assessments? Do we take a wait and see for different evaluations, whether it's learning, psychoeducational, whether it's, autism. And for us, the gold standard is the ADOS and the ADIR. And then, as you said, the GARS we use. So this really does help. Where the problems exist, which is going to lead me to some of the research, is sometimes parents are in denial. I would like to say they don't want to see some of these symptoms. And so when they give us a history, they are not as open about the history. And again, this happens to me a few times a month where I'll sense something, have a communication with a school, and what I'm seeing, the school is seeing, but the parents sometimes, Vera, just will minimize that. Because also, as a parent, and you're a parent, we know how to read our children. So when they have a need, a want, we can almost speak and do for them and
Yeah.
see, right? So we may miss things.
Right. Right.
because you read your child so well so you don't see it. So it's not, of course, done purposefully. It's more or less they're just not aware because they're so in tune to their child. And if they don't have multiple children, or even when they do, they don't necessarily see all that maybe we're seeing that may be indicative of autism.
Right. And I think you made a very good point about denial. And I would say that we have to help parents become aware and come to terms with the diagnosis, knowing that if it is autism level 1, what does that mean? And what does it mean in terms of treatment, right? Which we can talk about it later, but it helps understand some of the puzzles that don't fit necessarily to another child with SM that doesn't have ASD. When I do interview parents and we have the questionnaire that we created, we also do questionnaire and interview. We ask questions and they say, how did you know to ask that question? Like, I have to wash the shirt every day and dry it because otherwise my child is not going to wear any other shirt to school. Or I have to give chicken nuggets from Wendy's and French fries from Burger King, or my child has a repetitive behavior or very, very isolated interests in, let's say, dinosaurs or puzzles or Legos. And if we don't ask the question, right? If we don't
Yes.
do those questionnaires and if we don't ask the question, we may not have the clear picture. And in terms of denial, I think people have denial to the diagnosis of autism when they don't know much about it. And when we tell them the benefits, although many very bright and professionals in our area, parents, may be in denial. But when we show them, parents, the benefits of understanding the levels of impairment, also where they come from, it's really important to develop an intervention for a child who has repetitive behaviors or who has special interests or who has difficulty with social skills. It is different treatment plan than a child who just has selective mutism and is now 12 and didn't learn the social skills necessary at school, but is practicing those skills at home and has theory of mind and understands that. So I think when we join the parents in compassion and empathy, and we explain to them why a diagnosis of autism, in addition to SM or instead of, is important in terms of treatment plan, interventions, that they are better results because they are targeted to that. One example that I would love to discuss with you is the perfectionism that children with SM may have, a group of children may have. Usually it's not the same group that has the speech and language disorder. It's the another group that I see in general, but this is not scientific, it's just clinical impression of mine. The perfectionism and the tendency for obsessions and compulsive behavior and the sensory modulation difficulties that you and I talk about, food restriction, it's tags, or you talked last time we had a podcast, you talked about visual hypersensitivity and auditory. We have that. It's a little bit different in SM and ASD and how we treat that. So, depending on the diagnosis, we do different interventions for the child. And that's why the better diagnosis and the more refined, the better outcome is possible. You agree with that?
No, I absolutely do. And I think that's a really good segue, an excellent segue into a few things. One is the value of getting these children truly evaluated, whether it's autism testing, if we suspect it, in terms of validating, also helping parents understand to be able to develop appropriate school-based accommodations and interventions, as well as, community resources if they do have autism. But one thing that you said leads me to treatment considerations and how to kind of differentiate between the two. Because we know kids with SM, right? Even kids that have more of a timid, highly sensitive nature that aren't on the spectrum, they tend to be more sensitive. They tend to be more sensitive to tags and hugs and hair brushing. And we talked about visual processing, being more of a picky eater, may have more toileting difficult behaviors because of their difficulty regulating emotions, eating issues, sleeping issues. That exists, right? It's not that it's an SM issue. It exists with SM. I think the extreme is there. And what I notice too is that the internal kind of motivation and understanding tends to be lacking more in to talk about differentiating them, what I see clinically, because we know the clinical experience will precede any research done. So the neat thing about what we do, me and you, is we see all this clinically, right? And so do so many others. But because we see it, that leads to let's do more research on this, because you don't know what you don't know. But we know that you can have SM and autism, and it's difficult to diagnose for some. But that what I see with individuals, the biggest things that I see for differentiation is the internal motivation is just not there as much with individuals on the spectrum. They just don't have that internal drive. If I do this, this will lead to that, which will help me do this. That is what I see as a big key factor. Do you see that?
I don't know how much of that I see, but I think that what you were saying is that the children with in the spectrum, they don't see ahead in terms of intentional and a more abstract kind of planning,
Yeah, that's
manipulative
what, yes.
or and when we
Right.
speak, like you just use I can just use an example of what you just said. You said this serves as a segue for something else, so you're already linking what we were talking about to something else that you want to talk about. So that's something that is difficult for most of the children with autism to have. I think that there are some differentiations that I would like to note in terms of the visual contact, the visual. Sometimes children with ASD have difficulty with eye contact, and the children with SM have when they are expected to speak. But with their parents, if they don't have it, then we think about that. And I just had this week, I had a teenager who was in the office with the parent, and I saw the eye contact that happens, but it doesn't happen with the other ones. So I think that of course, the social interaction, the quality of it at home versus at school or other places. I think that the restricted interest we talked about, and it's more common in the children and adolescents with SM. I think that there are other areas too, which is the body language, the nonverbal behavior for children with SM may be typical with their parents, but not if they have ASD, may be atypical, the quality of tone of voice and all that. And I think that there are other areas too. And one of the things too that you mentioned is the sensory modulation difficulties. And we did speak before that many kids with SM have such high levels of difficulty with sensory modulation, but they kind of control it at school at times. Some of them don't, and they develop defiant behavior at school in their with their SM. But most of the children go home, and that's when they let go of their control of the modulation, and they are extremely bossy, defiant at home. So we have to work with that behavior that is the origin, like you said, is really modulation, anxiety, emotional modulation difficulty. But we have to work with the parents at home, and in other ways, we work with SM at school. So I don't know if I answered your question or not, but
Yeah, I think it's more of like they can be motivated to do a goal like right in the moment. I always see it as in the moment. So if they're working on skills, and I just want to bring up the eye contact, the flat affect, and that as a big misdiagnosis. I'm not a misdiagnosis as much as a misunderstanding. How about that?
yeah,
And maybe a misdiagnosis, and
right.
then we can get into some kind of treatment considerations as well. But what I see when someone is uncomfortable, whether they're sensory overloaded in a setting that's loud, large, lots of people, whether it's something that's causing them anxiety, in my opinion, not always even just speaking, but some kids that have learning challenges, their anxiety goes up, they become very flat. They have a speech and language deficit. They can't put their thoughts together to say it. So to me, I always say it's like having a fever. Why do you have a fever? Why do you have anxiety? And so figuring out why these kids have anxiety, not just they're socially anxious, or, I mean, yes, they may have that, but I see anxiety exists for other reasons other than a typical social anxiety. It's that these other challenges or these other Y's of SM can cause anxiety. So, on a personal level, those that know of my work know that my passion began with my own child. So she had been not talking in school. She was completely like flat affect, very little eye contact, sat there, kind of stared at her paper, didn't interact with anyone, a very typical, almost ASD presentation. But yet she got out of the school building and she was the most verbal, inquisitive, chatty, social, talkative child. And it was a tremendous differentiation. But when she was going through this, and this, she's now turning 30, I, was being told by so many people, she needs to be evaluated. Remember, 30 years ago, right? Or 30, I, not 30, like 25, 26 years ago, I took her to people, right? And I was told she had autism. She was on the spectrum, and I would pretty much have to have her have severe, uh, intense treatments. She probably would never really function in the world. I mean, those that know my Sophie know she's a
Yeah.
incredibly competent young woman who's a physician. She just got board certified in family medicine, got married to an amazing guy, social with a lot of friends. She's as incredibly neurotypical as you can imagine. And so if I had listened and I didn't understand, and although I didn't understand nearly to the level that I do now, this is what's happening to parents. They're getting caught up in someone that doesn't understand that lack of eye contact, flat affect in the moment or in the situation is not indicative of ASD. What is that child like at home? Again, I want to be clear. What is your child like at home?
Exactly.
They may be more, right? They may be more functioning with ASD at home, let's face it, especially if it's a very sensory overloaded environment. Speech and language deficits are more, what, as Dr. Evelyn Klein says, deconceptualized language out of the house. It's in the school environment, so it's harder. And parents, again, can read their child. Oh, you're thirsty. Oh, you want milk, right? Like the child isn't even putting their thoughts together to say it because the parent is reading them.
Yeah.
So my point is, a big differentiation to me is, what is this child like at home? What are they like out and about? How are they, have they ever had friends? Are they, when they're even with their siblings, do they have normal reciprocal back and forth conversation or social interaction? That to me is a huge differentiation, because you can have SM and be completely, even if you have language issues, right? We know 30 to 40% of kids with SM have some language issues, specifically expressive. So they may not be the most chattiest child at home, but they have appropriate social interaction. So it's more social comfort versus social skills, where kids on the spectrum lack the skills, the social know-how, and that causes them tremendous disconnect.
Yeah, I love what you said now, and I wrote down, I'm always taking note. You said it's more social comfort than social skills. And I think that we know that kids who grow up with SM are not appropriately treated, they don't develop the social skills, but they can more quickly develop the social skills
Yeah.
because brains are wired. Let's remember that autism, the brain is wired differently, and that's why there is difficulty with social skills and relationships. I just want to give an example to illustrate what you just said. I saw a girl a few months ago who was diagnosed with ASD, autism by one professional, was diagnosed with severe mutism by the teacher, who really couldn't diagnose, but they were concerned about that. But they didn't do anything about 504 IEPs, at school. And I was called in. And again, I listened to this girl at home. The parents gave me videos. And I also listened to this girl at school, and she was actually talking and screaming during recess with the other kids, kind of being a leader. But when the teacher asked an open ended question, she didn't answer. When I trained the teacher to ask a forced choice question, like instead of asking, how was your day or how was your weekend, which is an open ended question, she asked, did you go to the beach or did you stay at home? And she was able to answer those questions. I immediately raised a question about apraxia of speech. And so that was assessed by a speech and language therapist, and that has to be somebody who is trained in SM. Like Evelyn Klein says, she has a protocol for that. So we can have like a speech and language assessment at school if the person is not, if the child is not going to talk to the person. This kid did, because she didn't have SM at school. Only when she was asked questions that were open-ended and she was being tested with open-ended questions. Once she developed more comfort and self-assurance that she had some right questions to answer, she improved with her symptoms of what one thought was ASD, because she didn't talk to the teacher in certain situations and they thought she had ASD, and with the other people in the school. So I think that we need to be very careful and look at all those areas and all those other comorbidities that you mentioned, and to see not just if they are along with ASD or with SM, but also what else do we need to address to understand this child's impairment a little bit more, right?
Yes, no, definitely. And I see that a lot, that individuals with autism, they aren't as scared to talk. It's that they can't formulate speech in a way that most people think they can. Like you said, the open ended. So, what I find interesting, and again, I don't have research, but just clinical data, is that kids on the spectrum with SM, if they have the ability to speak, obviously they have to be even diagnosed with SM, they speak quicker than many other kids. It's just how you ask those questions. And so that's a big key consideration. Is I see this a lot where they become verbal very quickly because they become verbal to the capacity they can become verbal. So if they're not able to handle open-ended, thought-provoking questions and having give, take, back, forth of conversation, it's it's you asking the choice, prompting if they're able to obviously write and read. They do that. They're not scared. They're not doing it in these settings because people aren't asking questions the right way.
Right.
So when we talk about treatment considerations for autism, what I always do, what I train my students on is that you have to kind of pull things apart. You can't look at this as a smorgasbord. You
Right.
can't say, oh my God, there's a million things going on. You pull them apart and you address it, but you address them separately, but together. Meaning, here's what I mean. If they have toileting issues, you deal with toileting issues at the same time that you're dealing with social communication. So SCAT being a social communication anxiety, CBT based treatment protocol program, we still use the same concepts, right? So when we're formatting school-based accommodations, although friendships are difficult, and they are for kids on the spectrum, we will still try to implement a buddy process which is more teacher facilitated, having either a one-on-one aid, not always because funding's difficult, but having set times to interact with peers, because if you wait for the child to do it, it's not going to happen. We implement the small groups. We implement the small groups out of the room. We implement activities that the child can do, but with help. And so when speech is difficult, I find the kids can play these games and get immediate rewards rather than if I work and I have 10 stickers, then I'm going to get that, or 10 tokens, and then I'm going to get that, which will lead to this, which will lead to that. It's got to be more automatic. So they'll work on their interviews, and many of them don't even need rewards. They'll just do it when you set it up.
Right.
So a treatment consideration is, I find, more parent and teacher involvement more than ever with kids on the spectrum, because they need to facilitate those changes. And unless those parents and teachers are working with somebody that has an expertise, you're going to get all confused because you still need to understand their baseline. Are they completely mute in school? Is it because, how many times have you seen a patient that comes to you that is mute in school, mute with aunts and uncles, but you sit them down and within 5 minutes, they're answering, like you said, either choice questions or time to reflect, warm up time in a quieter environment, like you adapt it and you intuitively from your experience know, and the child becomes verbal. And then not only are they verbal, but you get them to be initiative because they can write and read or just read. And then they begin reading questions to you. So you go out in the waiting room, or not in the waiting room, but in your office, you meet with the parents, and they're like, he was pretty shut down, right? And you're like, well, in the beginning, yeah, he was, but with some warm up and of course, focusing on his interests, he was able to respond, and he actually asked me questions, and they look at me and they go, there's no way that's true. And I'm like, well, let me tell you how that happens.
Right.
And then I explain it,
The skill.
bring the child in, and they do it.
Right.
And it's like, how did you know? And it's like, part of how we know is the years of experience and intuition. What can I tell you, right?
Yes. Yeah, I think that that's a very good example that you're using. And I tell parents that the treatment for SM in general, there is no secret. And if somebody tells you there's a secret, like play therapy forever, then this is not the right thing to do, because with experience and with also some evidence from research, we know that there are certain skills that we can use and certain ways of interacting with the child that may facilitate. And that's why I like to be in the background. I like to be training parents and teachers on how to use the language that they do in order to obtain and to create a more comfortable social experience for the child, that they will decrease a little bit of the anxiety of the child. I think it's a very important point that you made. And in terms of treatment, I really like what you said about autism plus SM and SM alone. We need to know what's impairing the most. And sometimes, really, I've had cases of level 2 or 3 autism with SM, where I really needed to treat the ASD symptoms that were self-destructive or they were aggressive towards teachers and to other people in the classroom before we could address the SM, because the child couldn't receive a compliment, or because the teacher couldn't be that close, or if somebody took the child's pencil. So there was a lot of difficulty with territory and also with interaction with the teacher that we needed to take care before we treated the SM. And we need a multidisciplinary team for that. And when we have a speech and language disorder, we really need to have a speech and language therapist that is trained or is guided by somebody who is an expert in a selective mutism.
Oh yeah, those are excellent points, and that's why working with Dr. Evelyn Klein and developing that study of how to assess mute children, and we do this also at the Smart Center. We have to offer assessments because these kids need to be assessed, and many times, as you said, schools don't know how to assess them for IEPs, and a lot of private professionals don't know how to deal with SM and be able to even differentiate that. One of the things to consider also in treatment is adapting the strategies and the interventions to their developmental age. I had a 16-year-old that had SM and autism, 16, right?
Mm-hmm.
So they were functioning, though, at like a 6 or 7-year-old level.
Wow.
Therefore, we needed to adapt the goals, and as I call for younger children, the games for a 6 or 7-year-old. Giving them unrealistic goals for a 16-year-old, which is what I see, amazes me sometimes. It won't work for that child. So when he did interviews and he could speak, his speech was obviously delayed, and he obviously had difficulties in different areas of his speech and language, but he could speak, and he had the reading level of a 6 or 7-year-old. So when he met with his aunts and uncles, or even with his teachers, we did some interview or what's your favorite for Thomas the Train.
Right.
So he was able to not only ask questions because he had the pictures. So who is your favorite, who is this? And it was like Thomas or Freddie or whomever. I don't know. I can't even remember half the names. And he did it. So the point is, it's the practice at the level that they can be at to reach their capacity. It wasn't about him being mute. He could speak, but it was at his capacity of speech. So what I tell families and what I tell schools, and I'm sure again you do this too, is that we can't cure autism. We can't cure it. We can help them reach their capacity. And I learned that when we were doing research on SM, from Dr. Sharon Armstrong, because as a physician, I am taught to cure. I am taught to cure. That's how I'm taught from the minute I enter med school, curing. And it's hard because when you're in a field like this, yes, I believe you can cure SM. I'm going to put it out there. You can completely overcome it if you have the capacity to be a confident social communicator of a neurotypical, doesn't have the innate speech and language or even develop those skills. You can overcome this. But with autism, there's going to be autism features all along. It's how do you accommodate them and how do you provide those interventions to help them reach their capacity. Do you agree with that? Do you see that too?
But I'm going to tell you that I just had a meeting with child neurologists on this topic too. And the new research that Ami Kim has been doing for many years, using the machines to see eye contact with the little babies, they are now able to observe under 9 months old if babies are showing signs of features of autism through that very specific tool, and they are stimulating children. I'm not saying that it cures, but because we don't know yet, but there is hope on if babies are seen very, very, very young, which is the future, is not here yet. Those machines are not available commercially yet. They are at the university still, but there are ways that they are treating autism if it's really early in life. But we are talking about children who come to us already. Usually children are diagnosed with SM about 2 years after they show symptoms. And that's why I always say that the earlier the better. And they come at maybe 4 or 5 when they are in preschool or kindergarten, and they already had symptoms at the age of 2 when we could notice that they were developing language and didn't speak in certain places with some people, but yes, with others, going backwards. But that was the critical time to treat ASD, before 2. And that's why it's really important to screen early. So parents who have a child with ASD or who with SM, it's really important to screen for ASD, but also other siblings too, early as possible.
That's great information. That's wonderful. Thank you for sharing that. We did talk about different cases. We talked about being misdiagnosed with SM but having ASD. We talked about having SM without it. I mean, we've talked about a lot of the different cases. Do you want to summarize the recent research you just did, which I found fascinating? And I also found it very validating because it's what you see again clinically. You had about 136 kids in that SM and comorbidity study that you did. Do you want to discuss some of your highlights?
Right. Basically, we found that 32% of the children had characteristics of ASD, the children who were diagnosed with SM. This is 5 times more than the general population. So the recommendation is whenever you see SM practitioners, professionals, you should really screen for ASD too. One can mask the other, and vice versa. If you see SD, like you said about Sophie, that you should check for one or the other. A lot of the children have social anxiety, and the way to differentiate a little bit is that the children with ASD had with SM versus the children without ASD who had SM had more motor delays and speech and language disorders and delays. So that's one way, but that's our sample. But I think more importantly is to look at what are the other impairments and neurodevelopmental impairments that the child has, because the proposal that we have is really that SM is just not an anxiety disorder. And I'm going to say it out loud. And I know you agree with me for that. So, and there are some researchers in Europe, to Maurice and Nollendick, who also state that SM is part of a neurodevelopmental disorder, and there's a continuum between ASD, SM, and social anxiety. I would go as far as to say that when we have SM, it's just going back to the beginning, as you said. When we see SM, those are the symptoms, and we're going to work with that. but we need to see what is behind that. And I tell people, why do you think your child developed SM and another child didn't? I have a lot of parents who say, oh, I just think that she's being defiant or he's being defiant. And we kind of clarify this to parents. There is something behind it. There is no child who wants to not be speaking at school if they only have SM. If they have ASD, they may not have the interest, but a lot of high functioning ASD children, level 1, do want to relate. So they do have the motivation to relate, but they don't know how to go about doing it.
Yeah, it's the
So,
social puzzle. The social puzzle. It's their
yeah,
inability to figure it out and know what to do. And in comment to your study, which again I thought was great, and I think it'll really help the community, is you didn't, in that particular study, I would say that the sensory piece being connected to autism. And again, one of the problems with all these studies, and we saw it with ours as well, because we saw a higher percentage of autism than we did in the general public when we did our studies, and we quite a few years ago, is that this is based on parents. We weren't doing objective autism,
yes.
testing.
And we just,
Right. So I believe it's higher. I actually believe it's a higher percentage
okay.
because I think about the number of families we see at the Smart Center in a year. And then I think about the number that come with SM and autism. And I'm concerned with how many are diagnosed with autism that SM is missed. And so, in other words, I think it's a higher percentage, Vera. We only came up with 4.5% in the study of 1,500 kids. And I think it's actually a little bit higher than that
Yeah,
because I think there's families that just don't realize it and they just don't know what they don't know. And I think if we did actual objective studies, which is definitely something for the future, and we did objective studies on kids with SM, I
yeah,
think we'd find a higher percentage. How do you like that? Again, like you said, level 1, more functioning, because the ones that aren't as functioning, they're very obvious. It's the ones that are teetering on, and again, the differentiation between that social puzzle, the repetitive behaviors, it's very interesting. Yeah, no, this is just amazing. So we
I
talked about.
I just want to mention that Anita Panjwani and Dr. Andy Zimmerman were the co-authors of the study. So just wanted to mention that because it's just not my study.
Yeah, no, for sure. So basically, for treatment and school-based accommodations, the treatment for SM is still there, right? You adapt it to that individual's developmental age and their more extreme needs. More sensory for sure. They're more picky eaters. They have more extreme in some of these areas, like you said, the motor delays. And then also the social engagement, which from Stephen Porges years ago, 2006-ish. So it's almost 20 years at this point. I visited him in the University of Chicago because I was intrigued by social engagement because we saw it's not just about not speaking, right? But it's about social engagement, and individuals on the spectrum really, really struggle with social engagement. So the acts of stimulating social engagement, training parents to step back, practicing these skills in, less crowded, less overwhelming, less, noisy environments like the loud, large, lots of people, practicing handover, takeover, frontline, all the basic skill building or exposures that you do with SM without autism, it still works. I mean, that's what we do. But if they're obsessed with Thomas the Train, or they're
Right.
obsessed with, I had a child recently obsessed with ceiling fans. So his I wasn't trying, you don't want to dismiss what their interests are, but if that's what took, that's his interest, right? We use that as a way to engage him with somebody.
Yeah, I just want to give you an example of one kid who came and he was drawing bones and bones and blood all the time. And the parents were concerned. And so he had SM, and of course, he had ASD. And what we did is through drawing, we went from bones and blood to a skeleton because he really wanted to study the human body. And we went and I got like models of skeleton, and he was learning about the different bones of the body. Then he built a skeleton, and then he looked at the other. So he branched out to other things to draw. And I think that's really important. Oliver Sacks is one of my mentors too. You are, but he was before in the area of ASD, and he always talked about we have to go where they are, and so does Temple Grandin also says that we have
Right.
to go where
That's
they are
absolutely true.
and bring them out of their world, but we really have to understand what they are. And I think that's why it's so important that we do the diagnosis, the differentiation, so that we can make a treatment plan, just like you said, SM, but taking into account all those other factors of ASD. So
No, I think this was just such a wonderful discussion, Vera. So thank you, thank you, thank you. I love working with you. I wish we lived in the same
yeah,
city.
like I said before 2 years ago, maybe one day, I just want to say thank you so much. I think you're reaching out to parents, mainly parents and professionals in other places and countries. If you're listening to this, remember what we said, that it's really important for parents to be advocating for their children, starting from a pediatrician's visit.
Definitely.
Insist, because it takes pediatrician 2 years to recognize SM. They have to screen for ASD when the child is under two, twice. They have to screen for ASD and advocate for your child at school. Make sure that if you have SM, to not have an IEP based on just speech and language, because that's wrong. It should be included with anxiety disorder, which could be other health impaired. So make sure you consult Dr. Shipon Bloom's website, and I'm available too for any questions. But you are the best person to advocate for your child, and do not be afraid to ask questions of the pediatrician or anybody who is treating your child. Thank
And here's something interesting. If it doesn't feel right, it's not right. So if you are talking to your pediatrician or your family doctor or your teachers or psychologists or anybody, any of the therapists, if it doesn't feel right, it's not. And I think that's validating for parents, because it should feel right. It should connect for you. You may not understand it all, but it should feel right. And you should use your treatment provider to guide you in this process, to help you, to hold your hand, because I understand as a parent how scary this is when you don't understand what to do and what the next steps are. And I think it's really, really important for parents to feel that support as they're going through it. And that's a huge part of what we offer and what I know you offer. And I think this was great. I think this lends itself to more podcasts on autism, more research on autism, more information on autism and SM. I just think that there's just such an abundance of information out there. And I just think it's just, and anyway, I'm just thrilled. This made my day,
me
made my week.
too.
And I love working with you. And I know we're going to see each other soon. So
Thank
thank you,
you.
thank you, thank you,
Thank
thank
you
you.
so much. Thank you. Bye bye.